We're going to talk today about the challenges of dosing medication for OCD in the perinatal period and about challenges with polypharmacy. To really understand that best, let's talk first about the experience of one patient. Mary P. suffered from severe obsessive-compulsive disorder that had resulted in 2 previous hospitalizations. She had been stable for over 7 years on paroxetine, which she credited with saving my life, and occasional lorazepam. She wished to pursue in vitro fertilization due to male factor infertility. And her reproductive endocrinologist required a letter from her psychiatrist stating that he authorized her use of paroxetine in pregnancy. When Mary arrived in her psychiatrist's office to obtain the letter, he announced that he could not support the use of a Category D drug and would no longer prescribe paroxetine. Instead, he would start Mary on vortioxetine, a new drug that carried a Category B label but was not FDA approved for OCD, lacked human data about its safety in pregnancy, and had never been used by the patient. Mary switched medications as instructed, became pregnant, and within 6 weeks became severely ill. She eventually required an inpatient hospitalization and 4 different medications, including a switch back to paroxetine, to achieve stability. When she was well again, Mary said, "I wish I had known that staying on paroxetine was an option. I would never have stopped it if I had known." The treatment of OCD is challenging at any life phase, as a significant number of patients will not respond to initial treatment. Furthermore, one of the initial treatment strategies that has the best evidence is a psychological treatment, cognitive behavior therapy with exposure and response prevention, or ERP. That's a form of treatment that requires considerable motivation and commitment on the part of the patient, as well as access to a therapist trained in this form of treatment. Many patients with OCD require a number of trials to settle on an appropriate medication regimen. The average duration of untreated illness is approximately 17 years, and about half of patients do not respond to a trial of an SSRI. These challenges are rendered more significant in the perinatal period, when the mantra of prescribing is to use the minimum effective dose of as few medications as possible. Many patients, unfortunately sometimes advised by their physicians, will abruptly stop medications for pregnancy, leading to high rates of illness relapse that will sometimes require higher numbers of medications or higher doses than the patient was originally taking to return the patient to stability. It is almost always better to leave a patient on the medication that worked for her OCD, even if there are other evidence-based treatments for which we have more evidence of safety in pregnancy. Because most of our evidence on the risks of psychotropic medication in pregnancy is based on single agents, we have very little good data on what the risks to the fetus might be if agents are used together or are switched multiple times during pregnancy. It's also crucial to remember that the first-line treatment for OCD is either cognitive behavioral therapy with exposure and response prevention, or an SSRI, or an SSRI plus CBT with ERP. So if a pregnant patient is on an SSRI alone and not fully responsive, the first step should be to add CBT with ERP. Of course, some patients may not respond to CBT, and others, unfortunately, will be unable to utilize it due to lack of access. No providers who take insurance in their area, for example, or no insurance. It's also important to remember that the CBT must include the ERP component. This aspect involves having the patient face his or her fears and refrain from ritualizing or avoiding. The therapy is much less effective without this component, and many practitioners may say that they offer CBT but not offer this component. The first pharmacological step in pregnancy should be to ensure that you're getting the most out of the drug you are already using. Is the dose high enough? Remember that OCD in general requires higher doses of SSRIs than does major depressive disorder. And in pregnancy, changes in cardiac output, renal clearance, pharmacokinetics, and the volume of distribution will typically lower the blood levels of all drugs across pregnancy, some by as much as 4 to 5-fold, with some exceptions for individual women who are slow metabolizers of particular medications. So before augmenting or switching, make sure you are using the correct dose. Let's take a look at a typical dose chart for OCD. For those patients who do not respond to a therapeutic dose of a single medication, the best strategy is to follow the APA practice guidelines while also keeping in mind both the patient's history and the guiding principle of trying to minimize polypharmacy in pregnancy. The APA practice guidelines for moderate response suggest augmenting with a second-generation antipsychotic. Since we now have substantial registry data for those drugs that is reassuring about their safety in pregnancy, this is a reasonable next step. Strategies for little or no response involve switching to a different SSRI or clomipramine. This choice should depend on the patient's history. If she has a history of responding to a drug, use that. If not, use the drug for which we have the greatest evidence of safety in pregnancy. Often this means using an older drug. Remember that clomipramine and the other tricyclic antidepressants, or TCAs, have been around a long time, so we have more evidence about them than about much newer drugs. The TCAs can be very effective in OCD, and we have considerable data about their safety in pregnancy and breastfeeding. The fact that routine practice for these drugs includes serum levels makes them very easy to use in a period in which serum levels change rapidly, providing actionable evidence of how the pharmacokinetic changes of pregnancy and postpartum are playing out in one particular patient. Serum levels aren't a part of a routine practice for other antidepressants. They can be hard to obtain, not all labs will do them, and we have limited evidence of their clinical utility. However, as our understanding of the changing pharmacokinetics across pregnancy grows, they may become a standard part of perinatal clinical care in the future. In summary, it is crucial when treating OCD in pregnancy to remember that evidence-based psychotherapy, CBT with ERP, is a first-line treatment option, that doses of antidepressants are higher for OCD than for MDD, and that doses in pregnancy are also higher than outside of pregnancy. Most important, remember that we should try to minimize exposures for the baby, that psychiatric illness itself counts as an exposure, and that it almost never makes sense to switch a patient away from a drug that has been working for her and risk subjecting the baby to a new exposures of both an untried medication and relapsing illness. Obsessions are very common in the perinatal period and very distressing to mothers and mothers-to-be. Eliciting them in a non-judgmental way and treating them appropriately are crucial steps in improving the well-being of mothers and babies.